Good evening, everyone. It's my privilege to introduce today's esteemed speaker, Dr. Narendra JB, a renowned urologist from Mysore. Dr. Narendra sir has completed his MBBS and MS in general surgery from the prestigious JSS Medical College, Mysore, and further pursued his MCH in urology from the reputed Kasturba Medical College, Manipal. Doctor has over a decades of rich clinical experience in the field of urology and andrology, with a special expertise in the management of urinary tract infection, endourology, and laparoscopic surgeries. Currently, Dr. Narendra sir is practicing as a consultant urologist at a leading hospital in Mysore, where he has been consistently delivering excellent practice and patient care and advanced surgical outcomes. Doctor has also been involved in several medical conferences and workshops. And with Sir's vast knowledge and practical experience, Dr. Narendra sir will enlighten us today on current treatment in the management of recurrent urinary tract infection. And thank you all doctors for joining us today at Microlabs. Through our Eros division, we are committed not only to deliver quality medicines, but also to disseminate scientific knowledge that helps doctor to stay updated with latest advancement in patient care. Today's webinar is another stepping in the direction where our honored to have with us Dr. Narendra JB sir, a distinguished urologist who will be sharing his experience on current trends in the management of urinary tract infection. With these words, I now request Dr. Narendra sir kindly take over the session and enlighten us with your valuable insights. Sir, over to you, sir.
Thank you, Bhaskar. Good evening, all dear colleagues and my dear doctors. I thank my to the micro team to give me an opportunity to speak about some the common topics in terms of urological infections, that too in recurrent UTI. I'll be going through a journey of the how the recurrent UTIs and the introduction of the recurrent UTIs and its basic principles how to manage the recurrent UTI. I make it little scripts rather than more of theoretical because most of the clinicians UTI means dysuria. That definition should go on from the mind. We should always classify the UTI should be a complicated UTI, uncomplicated UTI, recurrent UTI, and chronic UTI. So we should always keep in mind, don't make a clinical diagnosis as UTI. Make a proper word. Make it as a complicated UTI, uncomplicated UTI, or a recurrent UTI, or a chronic UTI. With these words, I just start my slides. I will be talking about these headings. Yeah. So, regards from my own Institute of Nephrology, Mysore branch, where I'm heading the department. It is in the Care Hospital campus, and we are catering these services to all the people around in and around Mysore. So, the greetings from the Institute of Nephrology, Mysore branch. So, I'll be talking about the introduction of the recurrent UTI and risk factors for recurrence. Why this recurrence do happen? I'm not taking a theoretical class about what is a UTI basically and what are the microbial agents, basic microbial agents and biomarkers of these agents. And how do you classically approach the UTI and what our guidelines says about the how do you manage the guideline. Most common sorted guidelines what we use in urology is European guidelines and how do you prevent these recurrences of the UTI? And I'll conclude with the good take-home message of this. How do you go about this management? So, what is recurrent UTI? By definition, it's defined as having 2 or more episodes within 6 months. That is most important. Patient will comes 2 or more episodes of urinary tract infection with a culture positive, or 3 or more episodes in a year. See, you should not say any patient's men or a woman comes with a dysuria, you can't say it is a recurrent UTI. It should be an episodic, 2 or more episodes within a matter of 6 months or 3 or more in a year. So whatever, these repeated infection may result from either a new infection or relapse of a lingering infection sites. This may be a new onset of infection or maybe relapse from the harbored infection. The majority of the recurrent UTIs are believed to be caused by reinfection with the same bacterial strain. It is the undertreated urinary tract infection. It causes the reinfection. A relapse referred to the recurrence of UTI caused by the same bacterial strain after the completion of antibacterial course. So the fact is clear. We have to treat this UTI. We have to chase this UTI with an antibiotic culture and sensitivity. Don't treat any urinary tract infections with it should not go undertreated. Okay, what is this reinfection? Okay, second, my slide has gone a little bit. Yeah. Reinfection describes new episodes of UTI either involving the bacteria previously identified but following negative urine culture in terms of infection are caused by different bacterial species together. What generally we treat is we put an antibiotics. Whenever there is an antibiotic culture positive, you treat the patients with an antibiotics. We'll call the 2 weeks of antibiotics or three to 5 days of injectable antibiotics followed by oral antibiotics. Then we call the patients with an urine culture again, which shows the urine culture negative. We thought we treated well with the patient. So the patient symptomatically come down, patients also better. He has some residual infections like in terms of low backache or suprapubic pain or burning micturition or obstructive LUTS. We tell them to take continuous some analgesics and anticholinergics, which is the most common anticholinergic is Flavocid. So we have to follow up these patients for a long. So among the postmenopausal women, the annual occurrence of at least one UTI ranges from 8 to 10%. You got the point. In the postmenopausal woman, the annual occurrence rate of it is about 8 to 10%. For women with their reproductive years, the chance of experiencing second UTI within 6 months is about 26%. See, imagine. See, imagine the significant rise in the percentage of infection in sexually active men, sexually active women, and while a likelihood of third UTI drops out to 2.7%. What are the risk factors for recurrence? Why this urinary tract infection will recur? Okay, there are few factors have been explained here. Multiple sexual partners, existing urinary conditions, probably patient may be having outlet obstruction in terms of dysfunctional urinary bladder, what we call it as outlet obstruction, neurogenic bladder, the patients of lack of water intake, foreign body like long-term bladder catheters, we call it as COTI, catheter-associated urinary tract infections. Definitely pregnancy. Most of the pregnant women have a harbor the commensals, then they respond to the inflammation, then go on to the recurrent UTI. Menopause, I said the word menopause, and diabetes. Definitely, diabetes is the important cause for harboring the organisms, making a biofilm, which I am going to talk about what is called as biofilm. It is most important. So what happens in this slide? You can see frequent intercourse is a stronger risk factor with more than 9 times by 10-fold increase. Okay. Use of spermicides. Okay. Use of vaginal diaphragm. New sex partner within past year. After the age of UTI, see age at the first UTI more than 15 years. These are the risk factors for recurrent UTI I am talking. Imagine the girl having the first UTI about around 18, 20 years. We have to think about why she is getting the infection, whether she is using any spermicidal jellies for an intercourse or a frequent intercourse. Okay, is there an abuse, sexual abuse? The news, all these factors definitely count for the recurrent UTI. So there are some behavioral factors. What is the behavioral factor? There is no proven link between the recurrent UTI and certain behaviors, but we can see the association between these kind of features. That is pre and post coital voiding patterns. Most of the time we say about what we generally as a urologist practices is if you have a recurrent UTI, tell the patient you should void urine after the intercourse. Okay. Okay. Then frequency of urination. How many times the frequency the patient will be having? Normally, we can say, I generally call in an OPD, how many times you void by morning 8 o'clock to evening 8 o'clock. Okay, if the patient says about 4 to 5 times, it is well acceptable. Up to 6 times is well accepted. In 12 hours, every second hourly, the patient can void, and it is also called as a normal. Anything more than 2 frequencies within an hour, it is called as abnormal. Wiping pattern and dosing. There are, see, this is most important. Some people uses the tissue papers. Some people uses the, vaginal douches. They use V-wash. I always tell them, never use V-wash when you are thinking about the cleanliness or maintaining the good hygiene. Never use the topical agents. Use of tight undergarments. Okay, you delayed voiding habit, that is most important. Most of the employees, what we see in my clinical practice, they comes to us, I never void. Once I peed at home, I will come back after my duty at 6 o'clock. See, imagine about 8 to 10 hours, they are not voiding they are not empty the bladder. See what happens, the amount of urine which is collected, which will commensals will harbor, then it will prone for an infection. So delayed voiding habits, use of tight undergarments, wiping pattern. You should always wipe. We should not towards the anal canal. Okay, so that is very important. And what are the host factors? What are the host factor in the sense, what are the innate diseases of the person? The patients with chronic kidney diseases, the patients with the CKD, what we call as creatinine more than 2.5, earlier we used to call as renal failure. Now we terms terminology called as acute kidney injury. So these patients definitely they have immunosuppression. They tend to prone for the recurrent infection. Diabetes, and a patient who is on diabetes definitely prone for recurrent UTI. Immunosuppressive drugs, the patient who are taking a lot of immunosuppressive drugs definitely have UTI. The patient who is on kidney transplant, it is also vice versa. He is taking a lot of immunosuppressants. Definitely, and the retroviral positive patients, these have recurrent UTI. So other host factors is exposure to antibiotic resistance bacteria. See, imagine the patient is not responding to any antibiotic, means it is an resistant bacteria. Okay, the multi-drug resistant bacteria, and patient is on indwelling Foley catheter. Imagine the patient is on chronic retention. He is not able to pass the urine totally. We tell them the patient should be on CISC, what is called as continuous intermittent self emptying. Okay, catheterization. So such patients, they should maintain a good hygiene to or not to get an infected into the bladder. And presence of nephrostomy tube. If they see these are the tubes, will keep this patient to decompress the kidney to get the better functioning. So these are the few host factors you should also keep in mind when you're talking about recurrent UTI. What are the factors that elevate the risk? Elements influence bladder function and emptying efficiency. Urinary incontinence. We can see a lot of our patients, men and women, they come to our clinic with a stinking smell. Okay, which say about probably they may be having urinary incontinence, or also called as overflow incontinence. Okay, these patients will be having definitely cause for recurrent UTI. And presence of cystocele. You can see this cystocele is nothing but a bulge from the bladder that will go to the anterior vaginal wall. It probably can present in the per urethra also. There are grades of the cystocele, grade 1, grade 2, grade 3 cystocele. These definitely having elevate the risk of recurrence. And I told you, residual urine remaining after voiding, most important. It should not be more. What we see, the post-void residue should be zero. Practically speaking, it should be zero. The moment you void, there should be no urine in the bladder. Practical should be zero, but in the consensus, we take about 7 to 10 ml of post-void residue is normal, or comparatively, what we call is a significant post-void residue is more than 1/3 of the pre-void. More than 1/3 of the pre-void. Imagine if it is the patient is having pre-void is 500 ml, patient should be pass about more than 350 ml, then it is called insignificant. If there is remaining about 150 ml in the bladder, we call it as a significant post-void residue. This again harbor the organism, there will be upper tract damage. A post-void volume exceedingly 50 ml is recognized an independent predictor for repeated UTI, particularly post-menopausal women. You should always keep in mind most of the recurrent UTI because of the anatomic structure, the short urethra, there will be an common in a woman. That too, we should see about in the postmenopausal woman, the more than 50 ml is also recognized independent predictor for repeated urinary tract infection. So any patient with an elderly woman having recurrent UTI, don't treat only with antibiotics, analgesics, anticholinergics. Ask the patient whether you are voiding totally or is there any meatal stenosis. Is there any post-void residues remaining in the bladder? That is most important. You should always keep in mind as a clinician, as a base practitioner, don't treat the post-menopausal woman with only an antibiotics. You should think about probably the patient is may not voiding totally. There may be a meatal stenosis because of the age-related estrogen deficiency. There will be vaginal dryness. So the significant post-void residue is the most important factor for recurrent UTI for her. So you have to think about that. Then you have to send to the nearby surgical practitioner, or basically the best the person to look about is a urologist. So infection related risk factor for recurrence. I am talking about all the risk factors for recurrence. So, no? The most significant indicator for repeat infection linked to the notably presence of blood in the urine and urgency during initial urinary tract infection. There is a research in Finland involving about women about 70 to 82 years with E. coli induced cystitis revealed that 44 experienced the recurrence within 1 year. So the recurrence is high unless you treat the cause properly. So after menopause, what is the role of estrogen? You should always keep in mind, unless you treat this, the recurrent UTI will not settle down. I just want to go through about what happens after the menopause, decline in the estrogen, which triggers in the several changes in the anatomical, morphological changes, reduction in the glycogen levels within the vaginal tissue, thinning of the vaginal lining, increase in the vaginal pH, make it less acidic. The rise in the pH diminishes the population of protective lactobacillus bacteria, creating an environment where the harmful gram-negative bacteria can thrive and potentially causes UTI. The thing is clear. If there is a estrogen, if there is a estrogen, there is always commensals will be grown well. There is no harboring of gram-negative organisms. The lactobacillus is a commensal which will be there in the urethral tissue. Collectively, these hormonal shifts disrupt the natural vaginal microbiome, increasing susceptibility to recurrent UTI postmenopausal women. This slide is very important according to me regarding the postmenopausal UTI. You have to think about vaginal lining, increase the vaginal pH. The causes of recurrence in case of low bacterial counts and negative culture. Why there is recurrence even in case of low bacterial count and negative culture? The explanation lies in presence of intracellular bacterial community that develops biofilm. I am the most important part of this recurrent UTI theory is about the biofilm, which I am going to tell about in the few slides that may help you to your forethought why these biofilms are very important. See what I mean. See, this is called as intracellular bacterial communities. Okay, that is called as biofilm. Uropathogenic strains like E. coli, such as CFT073, what are the names that we given in microbiology, that penetrate the urothelial cells that line the bladder, leading to formation of intracellular bacterial communities. This is called as these is commensal. They make the IBC is called as biofilms. This is the time you have to act. If biofilm is formed, if it is produced, the formation of the matrix and maturation, then the infection harboring takes place. The infection go into the unnoticed in standard urine cultures. That is most important. These infections, most of the time you see urine culture is negative, still the patient is symptomatic. Urine culture is negative, still the patient symptomatic because of these, they harboring these biofilms. These infections are often go unnoticed in standard urine cultures, contributing to persistent and recurrent UTI. When these culture negative infections may cause symptoms like unexplained painful urination and urgency, they are classified under as bladder pain syndrome. This is a different pathology. Okay, interstitial cystitis and bladder pain syndrome is a different pathology. It also called as, comes under a picture of chronic pelvic pain syndrome. Comes in picture of chronic pelvic syndrome. See, there is just inosculation of the bacteria over the cell, and formation of the microcolony and formation of the matrix. Then the matrix will burn and this biofilms will keep on rotating. You can see this is a clear-cut picture where is a culture negative. We can see early intracellular bacillary colonies. Okay, in the left side, these will not damage anything here. Here also there is an organism is harboring in the bladder, but there will be culture negative. Okay, this is called as early IBCs is a biofilm. Later on, what happens when you get a culture is when there is a disruption, when is a growth, when is this bladder cells, what we call as umbrella cell is the largest cell in the body, which is the lining of the bladder. That's what it is the toughest. Whenever the bladder is distended, it can distend up to the xiphisternum. That is a theory. What we generally say is the bladder is a very capacious bladder. Okay, these epitheliums will get harbored by recurrent infection. We can see the damages. In this picture, we can see we can able to see the culture growth. What are the microbial agents, common microbial agents for urinary tract infections? I have to explain about only 6 most common, very important we should think about. One is E. coli, second is Klebsiella, third is Proteus, fourth is Pseudomonas, Staphylococcus and Streptococcus. As such, we have to know about these configuration of these bacteria. E. coli stands out the chief culprit responsible for about 80% of the uncomplicated UTI which is acquired in the community. Whenever the E. coli positive, don't think about too much about eradicating the E. coli totally, because most of the time it forms a biofilm, and before the biofilm get disrupted into rupture into another colonies, you have to treat that patient. How to treat this patient with the formation of biofilm? Don't ignore any dysuria. Don't ignore any dysuria. Don't ignore about the frequency. Don't ignore about the low backache. Don't wait the patient to treat until the fever should set in. Okay. Coagulase negative Staphylococcus aureus. You can see the Staphylococcus are all the dotted structures. 15% of the infection. Klebsiella pneumonia accounts for roughly about 8% of the infection. And Staph aureus is implicated in about 8% of the infections. Proteus also is an organism which causes a lot of infections in the UTI. So what happens? There are some few insights. The group B streptococcus identified approximately in case of 2 to 7% of the recurrent UTI. Infection caused by Pseudomonas species tend to occur more frequently among the individuals with long-term catheter use. Any foreign body, definitely this Pseudomonas has a picture. In diabetes, Pseudomonas is a picture. Proteus mirabilis prevalent is uropathy, especially in patients who indwelling catheters, spinal cord injuries, anatomical abnormalities affecting the urinary system. Don't think about the UTI is a big topic to understand, and it is very difficult to crack the subject. It is very easy unless you categorize the organisms what we are treating and what are the other associated manifestation which helps these organisms to colonize and make the treatment very harder. So we have to think about like the patients who was on foreign bodies like indwelling catheters, patient on spinal cord injuries. You probably all of you seen the paraplegic patients comes with a catheter. Okay, all the patients, we do divert the urine in such patients with an SPC or all perineal arthrostomy because there is no recovery at all. So as much as possible, the foreign body should be taken out. And spinal cord injuries, definitely there will be dysfunctional voiding syndrome. Earlier the terminology was called as a neurogenic bladder. Now we call it as a dysfunctional voiding because the patient is not voiding as normally it is. Okay, that's called dysfunction. Either he may enter the retention, either may be having urinary incontinence, either may be having lot of frequency. So we call it as a dysfunctional voiding. So how do you diagnose this patient? These are the risk factors. How do you diagnose patient? So basic perform routine analysis and microscopic examination. I said about the 6 organisms. Okay. E. coli, Proteus, Staph aureus, Streptococcus, Pseudomonas. Clinicians always think only these organisms. You should not think about the rarest. Okay, looking for an KH mount, Candida albicans, all those things. You should always think of the basic organisms in our mind. You try to look out the diagrams. If possible, if you have a side lab, you try to visualize. That is the best part of a treatment. So perform routine analysis, microscope examination, apply if you have a facility about the dipstick culture methods for preliminary, it is well and good. Utilize the leukocyte esterase and the nitrate dipstick test especially infection rates are below 2%. Conduct urine culture sensitive testing recognized by definitive diagnostic standards. That is most important. The collection of the sample is very important. You have to think about how the sample is collected. Most of the trained laboratories which have a QC, they collect good midstream urine. Number one. Two, patient which is hospitalized patient, how to collect the patient? They have a separate side port for a collection of the urine in a bag. Okay, these are the things we should follow protocol how to harbor the sample from the patient. So what are the basic imaging? See, this is about, I am not talking about the CBC. I am not talking about CBC and other things. I'm not talking about the total blood count, all those things. I'm directly telling about the imaging, what exactly you want to do about the imaging. Ultrasound. Ultrasound, more specific. What we have to look for ultrasound? We have to look for the bladder thickness. You have to look for the bladder thickness. Is there any mucus are present in the bladder, or there is the stones in the bladder, or any diverticulars in the bladder? To look about, diverticulars is again the harboring the post-water acid will be high. No specific imaging guidelines exist for a woman with recurrent UTI, and ultrasound also tells about the pyelonephritis, is the kidneys are bulky or not, and the signs of renal insufficiency also seen by ultrasound. CT gives a proper picture about the pyelonephritis, pyonephrosis, cystic kidney diseases. Serum biomarkers. Serum biomarkers, nobody does generally, but we have to have a picture about serum biomarkers. Patient with recurrent UTI showed significantly higher serum levels of immunoglobulins, IgG, IgA, IgM compared to the healthy controls. Early severe inflammatory response in equally predisposed to chronic UTI. So what are the serum biomarkers we see? Elevated macrophage CSF levels predict recurrent UTI. These are the evidence-based thoughts when you talk about the recurrent UTI. It's just not like recurrent, just treat the patient with antibiotics and call him for the next follow-up. So lower serum vitamin D in premenopausal with the recurrent UTI, that is most important. Serum vitamin deficiency may serve as a biomarker for recurrent UTI. This is very important. Always, whenever not able to control the infections, which is not fitting the diagnosis of the criteria of recurrent UTI, as I said, within 6 months of twice or 3 years culture positive in a year that fit into recurrent UTI. For an evidence, we have a serum biomarker vitamin D deficiency. That is also important. So some nerve growth factors about the urinary markers is a small protein support the neuron cell differentiation. Urinary nerve growth factor levels are significantly higher in women with overactive bladder. Elevated urinary nerve growth factor is a potential biomarker for overactive bladder. So the most common recurrent UTI is a persistent or recurrent asymptomatic bacteriuria. Most of the time, the recurrent UTI will be a consider picture of asymptomatic bacteriuria. If untreated, it can develop into acute cystitis and pyelonephritis. Most of the patient is asymptomatic bacteriuria. I am talking about a few things about what is called as asymptomatic bacteriuria. The guidelines for infectious diseases, significant bacterial without symptoms is characterized by presence of single bacterial species at a concentration of 10 to the power of 5 colony factor unit in a 2 consecutive midstream clean catch sample, then only we call as significant bacteriuria. Anything less than 10 to the power of 5, in the sense less than 1 lakh colony forming unit. When you see a report of urine culture, whenever the bacteriuria is less than 1 lakh or 10 to the power of 5, we call it as insignificant bacteriuria. Alternatively, a bacterial count of 10 to the power of 2 is or higher in urine via single catheterization of the urinary bladder. Absence of urinary symptoms accompanies these findings. Okay. So the significant bacteriuria, it should be less than 10 to the power of 5 colony forming units. What is the significance? Approximately 40% of women with asymptomatic bacteriuria who do not receive treatment till they progress to develop infection. Most of the time they will be harboring, they doesn't have any infection, and either they progress, then will get a treatment. This underscores the critical need to identify the consider the managing asymptomatic bacteria to prevent symptomatic cases. So what are the guidelines says about asymptomatic bacteriuria. Do not screen or treat asymptomatic bacteriuria in the following conditions. Women without risk factors. I said a lot of women with the risk factors. Patient with well-regulated diabetes. With a good diabetic control, no need to give an antibiotics. No need to treat the patient with the chase with an antibiotics. We have to follow the antibiotic steward system. Okay, unless you go follow the antibiotic steward for a program, it is very difficult because in coming years, we are being worried about the bugs. Bugs is almost killing us now. Oh, we should be very careful, judicious in using antibiotics. Postmenopausal woman, elderly institutionalized patient, patient with dysfunctional reconstructed lower tracts, patient with renal transplants, patients with orthoplastic surgeries. Do not screen or treat asymptomatic bacteria in patients with cardiovascular surgeries. Screen for and treat asymptomatic bacteria prior to urologic procedure breaching the mucosa. Screen for and treat asymptomatic bacteria in pregnant women and standard short course of single dose of fosfomycin trometrol. That is most important. Nowadays we have a single dose or a weekly once dose for a 4 monthly dose of fosfomycin, which is an oral antibiotic, is a newer antibiotic for this asymptomatic bacteriuria. What is symptoms acute cystitis? Most of the time, why I am taking this topic with an asymptomatic bacteriuria, the next symptoms will be a cystitis. Okay, there will be dysuria, painful urination, increased frequency, urgency to urinate, suprapubic pain without systemic illness. Suprapubic without systemic illness. Presence of blood in the urine, that is hematuria. Lower tract symptoms with pyuria, but sterile urine culture may indicate urethritis caused by chlamydia trachomatis also, which is harbored. How do you diagnose of the acute cystitis? Diagnosis to woman who has no risk factors for no other risk factors of systemic urinary tract infection based on focus history of lower urinary tract symptoms. We call it as a lower urinary tract symptoms, dysuria, frequency, urgency, absence of vaginal discharge. Use urine dipstick testing for diagnosis of acute cystitis. Urine culture should be done in the following situations. Suspected acute pyelonephritis. Okay. When you do the urine cultures, when you suspect this patient is going for a pyelonephritis, symptoms that do not resolve or recur within 4 weeks of completion of a treatment, women who represent the typical symptoms of recurrent UTI and pregnant women always you have to get a culture. So antibiotic treatment. Okay. Recent advances in antibiotic research focus on new compounds and technologies to enhance effectiveness, including synthetic antibiotics and combination target resistant bacteria. Risk of antibiotic. By the same time, when you talk about antibiotic, you should always think of the other hand. What is the risk of antibiotic resistance? The overuse and misuse of the antibiotics leads to antibiotic resistance, making the infections harder to treat and posing a significant public health challenge globally. So what is called as antimicrobial stewardship? Okay, I just want to stay some more time in this slide, which is very important. Although the benefits of the patients and use of the antibiotic use are clear, overuse and misuse of have been contributed to growing problem in resistance among the uropathogenic bacteria. So what the word says about is overuse and misuse of these antibiotics causes growing problem of resistance. In acute care hospitals, 20 to 50% of the prescribed antibiotics are either unnecessary or inappropriate. So to hear it is very difficult to digest this word, but this is true. In acute care hospitals, 20 to 50% of the prescribed antibiotics is either unnecessary or inappropriate. Doesn't need an antibiotic. Don't you think when the patient admitted, put the patient on zone and amikacin? So that concept should be go off on our mind. Any patient admitted with UTI or fever, we should not give an antibiotics on this stage. Okay, not a first line of treatment. In response, a worldwide initiative seeks to incorporate antimicrobial stewardship programs in healthcare. What is this? Antimicrobial stewardship aims to optimize clinical outcomes and ensure cost-effective therapy while minimizing unintended consequences of antimicrobial use, such as healthcare-associated infections, including Clostridium difficile toxicity, selection of virulent organism, and emergence of bacterial strains. Why I am talking about Clostridium toxicity? Because of the abuse, these become predominant. What are the important components of antimicrobial stewardship program? Regular training of staff in best use of antimicrobial agents. We should wait. In the contrary, I am not telling put all the patients on culture and wait for the culture and do the given antibiotic. That is not the way. Regular ward visits and consultation with the infectious disease physicians and clinical microbiologists, regular monitoring and feedback to prescribers for their performance and local pathogen profiles, adherence to national and international guidelines. Unfortunately, we don't have much guidelines about stewardship program as of now, which is not strictly followed in all our hospitals. To be frank, we have to follow this stewardship program. Imagine if I am going to change another antibiotic, the second physician's given consent. Why I am going to change the antibiotics? Such system we are not. If you go to the Middle East, people, if the physician want to shift from cefabrazone to piptas, he need to give another physician consent. See, that stringent activity is happening abroad because we have one of the largest democratic country in the world, because we need to. Our centers are also taking a lot of interest about the stewardship program. We should also think about, as a clinicians, judicious use of antibiotics and audit of adherence of treatment outcome. That is most important. See, there are EU guidelines and recommendations for what is the first line antibiotics we use. So earlier we have to use for ciprofloxacin, levofloxacin, cefotaxime, ceftriaxone. Second line becomes about cefepime, piptas, then about gentamicin and amic acid. So this is a course of antibiotics what we generally use. Nitrofurantoin also can be used for asymptomatic bacteriuria. I'm talking about in case of initial pyelonephritis. So this recurrent UTI, if you manage properly within if treating about the asymptomatic bacteriuria and also harbored antibiotics, then these patients cannot enter within pyelonephritis. So when the patient, how these patients they enter with pyelonephritis, when these patients is not, symptoms are not totally come down, when the culture is not changed properly, definitely it enter within pyelonephritis. These are the few recommendations of treating the pyelonephritis. Coming to the doses of oral penums, which is most important, which is using regularly now. So we have injective standard dose of imipenem celestine only patient with culture positives indicating multi-drug resistance. So these penums are very important for MDR regimen. These are not the first line alternatives. These are the last line alternatives for treating the recurrent UTI and morbid infection of pyelonephritis. That is most you should also keep in mind. We have quinolones. Quinolones is the first choice. As a clinician, what I am practicing is the first choice for urinary tract infection is first is cephalosporins. Earlier it was a quinolones. Now the second line is cephalosporins. Then we go for the third line alternative, penums. Okay, penum should not become in a front line. It should be culture positive and indicating in the MDR organisms only, indicating in multi-drug resistant organisms. We can see meropenem 1 gram TAD and other combination which has been given in our guidelines. So what are the newer antibiotics what we use? Phosphomycin, I think everybody knows about the phosphomycin. Even clinicians, practitioners are using as a single dose of 1 sachet in a week. What is a urologist, what we generally give the patient in case of recurrent UTI is the best drug, wonderful drug. We can give a single dose and it is a broad spectrum produced by Streptomyces species and a bactericidal action is a 1 3 gram sachet given to the patient after the food. Few patients have diarrhea as a commonest side effect for this. We should be used judiciously. The two more patients with an elderly patient, which is more frail, were not taking food properly. These patients definitely have one contraindication called diarrhea. This can be managed conservatively. Then patient will improve drastically with these kind of recurrent UTI. So this is about the dose schedule of the pyelonephritis. So what happens? Persistent acute pyelonephritis infection, if doesn't manage properly, lack of clinical improvement within the 48-72 hours, these go into persistent infection. It causes endotoxemia. Why I am shifting from recurrent UTI to pyelonephritis is you have to, these recurrent UTI, most of the patient, if you don't manage properly, they'll progress to the upper tract infections. Upper tract infection in the sense is pyelonephritis. It's a kidney inflammation of the pilus and the nephritis of kidney. So these persistent infections, with lack of clinical improvement, even after the chased antibiotic, it will end up in pyelonephritis. How to do these management of this persistent infection? You have to get a one-shot IVP, if it is, or also CTKUB plain. Obstruction relief is important. One most commonest method what we use for pyelonephritis is stenting. DJ, double J stenting is most important. A percutaneous nephrostomy is done only for pyelonephrotic kidney, not for simple pyelonephritis, which is an indication for drainage. What are the causes of persistent infection? For multiple microabscesses and macroabscesses, abnormal ureteral pellicle dilatation, intrarenal perinephric abscess, and kidney stones. So antimicrobial prophylaxis, continuous antiprophylaxis for 6 to 12 months significantly reduce the rate of UTIs during the prophylaxis period. There is no difference between the two treatment groups after cessation of the prophylaxis. Post-coital prophylaxis involves taking a dose of antibiotics within 2 hours of intercourse. Imagine, as I said, the risk factors for recurrent UTI, the coital habits, multiple sexual partners, they can, for the post-coital prophylaxis, within 2 hours of the intercourse, we can take an antibiotics. This is a scheduled program. If it requires a smaller amounts of antibiotics, can be continuous prophylaxis associated with the fewer side effects. What are the antibacterial prophylaxis? What are the drugs can be used? Cephalexin can be used with a low dose. Ciprofloxacin in 125 milligrams. It can be given for 6 months. We have seen some patients are taking for 6 months. Nitrofurantoin with a 500 to 100 milligrams. Trimethoprim sulbactam. And norfloxacin. We generally, earlier, I want to make it clear, most of the time in our undergraduate times, we used to give an antibiotic which is for UTIs, Norflox TZ. So we are not using the norfloxacin as of now. So most commonly antibiotic used are cephalosporins, quinolones, and nitrofurantoin, and then gripinums. These are the main tool for management of urinary tract infections. What are the non-antibiotic alternatives in case of UTI? Okay. So probiotics, this is most important when you are treating the patient with a recurrent UTI. Patient already taken a lot of antibiotics earlier. The probiotics can also restore the healthy bacterial balance in the urinary tract, potentially reducing the occurrence of the urinary tract infection and improving overall urinary health. That is most important. Think about using judicious use of probiotics when you are treating a patient recurrent UTI. What are the natural hormone remedies? Various natural remedies such as herbal teas, essential oils support body defenses against infections, provide alternate treatment alongside of the conventional medicine. How do you do the prevention of recurrence? Behavioral modification, avoidance risk factors, non antimicrobial measures like cranberry juice, probiotics, hormone replacement in postmenopausal women, antibiotic prophylaxis. In case of recurrent UTI with then meatus stenosis, I always tell the patient to take a lot of liquids and also use like cranberry juices. It also comes as native fruit, and also we can have in the syrup based. Always given primary ointment, which is important to moist the vaginal area because of the dryness. As I said, the glycogen deficiency causes vaginal dryness and lack of lactobacillus harboring. There is no commensals. The infection is more common. So antimicrobial prophylaxis is also important here. Prophylaxis with the cranberry juice. Drinking cranberry juice might have been most well-known prevention of recurrent UTI. It has been shown inhibit adherence of P. fimbriated E. coli to the urothelium, could decrease the virulence of the bacterial cystitis. Early RCT showed that cranberry juice decreased the number of symptomatic relapses over 12-month period with a woman with recurrent UTI. Hormone replacement prophylaxis, as I said, estrogen for preventing recurrent urinary tract infection in postmenopausal women. A Cochrane database study conducted in 2008 said that intravaginal estrogen therapy is a form of vaginal creams, ring pessary, significantly reduce the risk of recurrent UTI. Oral estrogen not effective to prevent recurrence. Vaginal irritation is the main adverse effect and may cause occurs in 20% of the women. Keep in mind when you are treating a recurrent UTI in a postmenopausal woman, always preferably use vaginal creams in terms of estrogen creams. What are the immunoactive agents for prophylaxis? Vaginal vaccine significantly reduces the risk of occurrence UTI. It significantly increases the vaginal and urinary IgA levels. A recent meta-analysis published in 2013 enrolled the clinical trials in a oral vaccine, that's OM89, showed that significantly decreased the UTI recurrence. EAU guidelines 2015 recommends OM89 for immunoprophylaxis in female. One of the possible pathogens recurrent UTI is adaptive immune response dysfunction, especially in the defect and recognition. Thus, the use of vaccine strengthening acquired immunity against uropathogens might be a reasonable prevention for UTI recurrence. I just want to conclude the recurrent UTI may be a most common problems in urological clinics. Treating UTI may not be difficult, but preventing UTI recurrence sometimes might be very troublesome for both patients and doctors. Recent research revealed that many novel concepts in recurrent UTI, including pathogens, risk factors, biomarkers for prevention. Nowadays, the recurrent UTI may be considered as a distinct disease. The patient with recurrent UTI should be managed aggressively before it going for a pyelonephritis and urosepsis. Okay. Further, basic science studies are needed to elucidate the details in pathogenesis. RCT is also necessary to clarify the efficacy of the current management. I said earlier about the non-antibiotic treatment is the treatment with the cranberry products, treatments with the phytotherapeutic, treatment with the xyloglucan, gellose, hibiscus, and propolis, treatment with the D-mannose. Most important lifestyle modification is diet and hydration. Proper nutrition, adequate hydration are crucial in maintaining the health. A balanced diet with rich fruits, vegetables, and water can help to prevent range of health issues. Hygiene practice is very important. Good hygiene practice such as regular hand washing, personal cleanliness play a vital role in preventing infection and maintain overall health. I said about the OM, that vaccine research, ongoing research vaccine aims to develop the effective vaccine that prevent diseases, reduce the incidence of illness within communities, and protecting public health. Surgical intervention may be necessary for serious health issues in terms of bilateral degestenting, in terms of PCN to divert the urine, in terms of removal of the stones, either in terms of endoscopy, either in terms of RIRS, either in terms of PCNL. Thanks a lot for again to micros department. Even though the topic is very small topic, I can able to cover whatever we been given recently for the recurrent UTI. I wish to take some good questions which have been common doubts which have been in the clinical practice. Thanks to Bhaskar who has been taking this program, and also thanks to Kiran who has been coming in Mysore. Last week he said, sir, we have a program, we can able to talk about the recurrent UTI. Even though the topic is very tricky topic, it is, we can't say it's a small topic or a big topic. It's most of the chunk of the urinary tract infection what we see in the community is recurrent UTI. They come to one set of doctors, they will change the doctors, they keep on going to the doctors because the symptoms is not settled down. The idea is we have to think about the risk factors of recurrent UTI, why the recurrent UTI is not settling down. So what are the things we have to take care about these patients should settle down, and we have to make the behavioral modification and about the personal hygiene. Otherwise, every doctor treat the same. These patients will keep roaming to the doctors because his symptoms are not settled down. So I reassure these symptoms should be assessed very properly. Talk to the patients, even if it is the postmenopausal woman, talk to them properly. Whether treat his outlet obstruction in terms of meatal stenosis, apply the estrogen cream. When the patient has taken long-term antibiotics, taper down to oral penums. Oral penums are wonderful nowadays. They can take care of these residual infection. That I can say in my practice. I can see in my practice how these penums are being used totally. Either only, not only because I said I am not talking about the urosepsis in totally. Urosepsis is a big topic in separate. So that's what these penums are used basically as a last resort. So you have to understand the basically pathogenesis of the recurrent UTI, risk factors, imaging, how do you manage these patients, what are the lifestyle modification, what are non-antibiotic drugs we can able to use, and counseling the patient. By this, I can end my topic, whatever I've been doing in my practice. I wish to take some questions which are valid
Sure,
for this
sir. Sure,
session.
sir. Thank you so much. Thank you so much, sir, for giving so insightful, and you covered almost all the thing. And few questions we have received from our this one because our staffs are with doctors. Dr. Shankar from Bangalore, sir. Dr. Shankar from Bangalore is asking, how do you differentiate between relapse and reinfection in urinary tract infection cases?
Correct. This is a wonderful question. See, relapse. See, relapse is a condition which is not treated totally. If you see the patient with a relapse occurs within a 3 months again, the patient come back with the same symptoms. In the recurrent UTI, the most common symptoms are dysuria, frequency, urgency, suprapubic pain. Only these symptomatology will be there. The relapse occurs when the UTI has not been totally treated with a culture negative. So the other thing is what is the other question?
Sir is asking difference between the relapse and reinfection in urinary tract infection cases.
That's
Reinfection.
what, sir. Relapse is with the same organism. Imagine that you are treating the same organ relapse, and reinfection is again a new set of organism.
I think,
Reinfection
sir,
is, yeah.
yes, sir. Sir, I will take selective questions because it's 1 hour webinar. And one doctor from Chennai, Shanmugam from Chennai, sir is asking, how long should we continue antibiotic therapy in recurrent or complicated urinary tract infection?
That's what, sir. I showed my previous slide. You can go up to 6 months also. See, this is the slide you can able to see. Continuous prophylaxis can be given up to 6 months or 12 months, depending upon the symptomatology. See, the most of the patient says we can see now you can use nitrofurantoin. What we generally nowadays we use nitrofurantoin as a long-term prophylaxis. The good drugs we can give for a prophylaxis is nitrofurantoin and ciprofloxacin. Nitrofurantoin and ciprofloxacin is a good long-term prophylaxis which doesn't have any complication in case of immunosuppression or in terms of bacterial host resistance.
Thank you, sir. Sir, Dr. Meera Matthew from Ernakulam. Sir, doctor, do you recommend prophylactic antibiotic in recurrent UTI patients? If yes, in which scenarios? Sir, madam is asking.
Very good question, because we are not able to give prophylaxis for all the patients. The prophylaxis is considered for the patients who have been having any foreign body, or the patient is on dysfunctional voiding symptoms. Whenever the patient has dysfunctional voiding symptoms in a neurogenic bladder, or the patient with the paraplegia having the spinal deformities, those such patients we give in prophylaxis. Prophylaxis is not indicated in all the recurrent UTI.
Okay, sir. Sir, one more question, because some RMs are keep sending the messages. Sir, there is a question from Dr. Damodar Reddy from Vizag. In patient with relapse negative culture but persistent symptoms, what is your approach? Is the question, sir.
That's what, sir. See, these clout of patients will always come to us with treatment of the recurrent UTI. They still comes with a culture negative organisms. See, I told you, never think about culture positive or culture negative, because these patients you have to rule out the any other causes of anatomical morphological deformities in the bladder, or whether you are treating a child, or you are treating an adolescent, or you are treating in sexually active men or a woman, or you are treating an elderly man, postmenopausal man. All these come into picture. If you if you are treating an elderly woman, we should always think about recurrent UTI due to an outlet obstruction and also due to estrogen deficiency. If you think about sexually active woman in a reproductive age group, you should always think about the number of course of antibiotics what she was taking, why the results has happened, whether she is harboring any organism in the upper tract. That is most important.
Okay, sir. Sir,
The
because
answer goes to the different category.
I'm in Ghaziabad, sir, today, and Madam Dr. Ritu Sharma from Ghaziabad, Madam is asking, what is your approach towards recurrent UTI in post-menopausal women?
That's what. So this is a common thing, you know. The approach in my approach in case of post-menopausal woman is most of the patient, I screen this patient whether they have a post-void residue or not. If the post-void residue is high, I evaluate the patient. I have to take up the patient for urethral dilatation and take the cystoscopy whether there is urethral narrowing is not. If there is urethral narrowing, we do calibration of the urethra. We have a procedure called as urethral stretch procedure, so that the patient will be having post-operatively, there will be nil post-void residue or insignificant post-void residue. If the post-void residue is insignificant, the harboring organism will be less, so the patient will be relief of symptoms. Number two, in post-menopausal women, always think about the vaginal health, giving the estrogen cream, and ask the patient to frequent voids, and you have to check for the check scopy after the dilatation, check for ultrasound in is any case of post-void residue remaining or not. These are the things will make the patient so comfortable. Patient comes to our clinic, says, I am voiding frequently. However times I go the urination, I will void little bit, and again they have a urge to void. That shows there's a high post-void residue, definitely causes lot of lower urinary tract infection.
Sir, I think it is a fantastic one. You covered all the things, sir. What I will do, I will compile the questions which I received and I will share with you. Based on your answer, definitely I will inform the doctors on this. Due to the
Any
time
more
constraint.
questions are quite interesting. I can able to answer because this is a common thing keeps on everybody's mind. The recurrent UTI, how to manage.
Absolutely, sir. Absolutely. There is a one question, sir. I think you are covered. Dr. Sanjay Agarwal, sir, is asking, do you see a role of probiotics, Canberry extract or D-manthos in preventing recurrence? It is the questions.
Probiotics are very important, sir. As I said you, the role of probiotics is very important because they makes the bacterial balance in the urinary tract, potentially reducing the urinary tract infection. That is very important. That's what most of the patients who are taking long-term antibiotics, we generally use the patient with the probiotics. We load the patient with the probiotics, and also we'll allow the patient to take the natural remedies. They can take the cranberry juices. We allow the patients with a lot of liquids, buttermilk. We can allow the patients with pineapple juices, lot of citrus fruits. See, this makes the balance in the bacterial balance in the urinary tract. That is most important. So whenever there is the imbalance of the bacterial tract in the urinary tract, that is most cause for recurrent UTI.
Is there any specific bacterial strains in the prebiotics, in the probiotics?
Lactobacillus, sir. It is one infant that strength I have not written. Most of these lactobacillus.
Okay. Sir, last question, sir, from Dr. Sadbir Singh. I think Sadbir Singh in our manager name, I think is from Punjab, sir. Sadbir Singh, sir. How important
Yes,
is patient counseling in preventing recurrent infections?
see, counseling is always important because the patient already has suffered. See, that's what in a age group, it depends upon the age group of the patients having recurrent UTI. So if you are talking about the patient with an newly married couple, I'm setting an example what is called newly married couple. They either they are initially they are new to the intercourse, the hygiene practices are less. We call it as a honeymoon cystitis. We call it as a honeymoon cystitis in most of the young couples. They come with an recurrent UTI. If they are not taken proper care of the antibiotics, they'll end up within pyelonephritis. We are seeing the patient is going for urosepsis also. This is a small scenario I am taking in a sexually active woman. So these patients, we have to counsel them. See, listen, it is like this. You have to take care of for your sexual health. You should take care of your hygiene. If you take care of your cultures, if it is, you should symptomatology, how the symptom it is, whether it's suprapubic pain, fever, flying pain. That also says about the patient will be on pyelonephritis. It is ahead of the UTI. So you have to counsel them properly. In case of young women, so in the reproductive age group, in the elderly, you should talk to them properly. How much she is the voiding. So since we can within a gap of 2 hours, how much times she is voiding, whether she is voiding completely, how the stream of the urine it is, whether she is voiding in a drops, whether she is voiding properly. These terms of questions makes them much more better. They can answer all these questions easily so that we can able to resolve the problem over the counseling.
Sir, one more question from Dr. Ranjit Kumar Patro. Ranjit Kumar, what is the first line antibiotic used equally and how many days?
So this is the commonest question. What in urology practice, the first line of antibiotics is cephalosporins. We use the oral cephalosporins 200 milligrams for 7 days.
I think, sir, almost all the questions we have addressed, sir. So far,
I'll tell a few things about the antibiotics, sir. Cephalosporins, what we generally earlier, 1 decade back, we are using quinolones as a first line. The first drug of choice was a ciprofloxacin. Earlier, there is one more drug called as Ciplox 1 gram, Ciplox 1 gram OD. There is a 1 gram dose. This is a loading dose was we are using earlier. Nowadays, quinolones always comes in a second choice. Cephalosporins comes in a first choice. For prophylaxis, we go for nitrofurantoin and also quinolones.
I think Dr. Ranjit from Behrampur asked that question, sir. Behrampur.
Correct.
Sir, thank you so much on behalf of Microlab Zeros division. I extend our heartfelt gratitude for your taking time for your busy schedule, sir, for delivering this insightful session. Really, we are enjoyed, especially in the current trends in the management of recurrent urinary tract infection. Your vast clinical experience and practical approach towards managing the recurrent and complicated urinary tract infection gives a greater value to many participants. And so many questions you have seen, you have heard, and it shows the still many doctors are having to know from you the clarity with which you have explained the diagnostical challenges, antibiotics mainly, and preventive steps. Surely it will help the medical fraternity, sir, by improving their patient outcomes. We truly appreciate your contribution in disseminating the knowledge and guiding us in the right direction. This session has been extremely engaging on behalf of for all the attendees. Thank you once again, sir, for your support and encouragement. We look forward to your continued guidance in our future academic initiatives. Thank you so much, sir.
Thank you for all attendees across India, and thanks Bhaskar and team. Thank you very much.
Thank you so much, sir.
Thank you, Biswajit.
With your permission, we will conclude the meeting.
Yeah, thank you.
So may you please record.